Hello there, my name is Dr. Douglas Gillard. I'm the owner, founder, and editor of ChiroGeek.com. Welcome to another video. Today we're going to talk about the normal lumbar spine and disc anatomy in part 1 of this series. And in part 2 we're going to talk about how to read your lumbar MRIs. Now this is not going to be totally comprehensive because it's geared for my coaching clients. So if you want to really dig into this and learn a lot more, go to my webpage, ChiroGeek.com, go on the anatomy page and the MRI page, and you will find a wealth of information. Now we have a lot of ground to cover, so let's get moving. Okay, now the best way to get through this material is by a PowerPoint that I've created just for this video. So now I'm going to put my head down and focus on this PowerPoint, and let's get moving. Now, this is a posterior to anterior view of a skeleton, and we are concerned with this region right here, which is the lumbar spine. Now, the lumbar spine is really made up of 5 lumbar vertebrae that are stacked off on a base called the sacrum. This is a triangular shaped bone. At one time, this had 5 segments, but by early adulthood, it's fused solidly into one bony mass. And notice how the lumbar vertebrae are stacked nice and straightly from this posterior to anterior view. This is also called a coronal view. Now, bordering the sacrum are the coxal bones, or the innominate bones, or you can just call them the hip bones. And they form an important joint here called the sacroiliac joint, or the SI joint for short. It's a true diarthrodial joint, which means it contains a synovial fluid and a capsule to hold that fluid in, and it contains nociceptive fiber, so it can become a source of pain in approximately 5 to 10% of people with chronic low back pain. Now, it's also a referral site for discogenic pain, and what I mean by that is people with L4 or L5 annular tears in their disc, it often refers pain to the SI joint. So you think you have a pain right here in your SI joint when really the pain is coming from the disc. So it's often confuses clinicians who are not aware of that fact. Now let's look from the side view. This is called a sagittal view, and we can immediately notice that the bones are no longer in a straight conformation. They're in what's called a lordosis, or you could call this a lordotic lumbar curve, which is very important for normal biomechanics. I won't get into all that, but check out my webpage and you can learn all about that. Now let's blow that up a little bit. Now here's a sagittal view from the other way. This is the front now over here. This is the back, and we can see 3 lumbar vertebrae here. Now let's talk about this term motion segment. A motion segment is nothing more than a vertebra, disc, vertebra sandwich. And these 3 structures are the functional unit of the lumbar spine. All motion occurs here. Everything of the motion segment is named in accord with the bone above. So this is the L2 vertebral disc of the L2/3 motion segment. This is the L2 neuroforamen, or intervertebral foramen, or just IVF for short. And this is formed by the pedicles, mainly, of the top and bottom bones of the motion segment. This is very important. There's one on the left and one on the right. Because the exiting lumbar nerve roots come out of this hole, then they go down into your pelvis to form the giant sciatic nerve, which of course controls everything about your lower extremities, including your skin, your muscle, even your blood vessels. So this is a very important highway right through here. Now let's introduce you immediately to MRI. This is a T2 weighted MRI. It's a sagittal view. Here's your front, here's your back, and you can see in this mid-sagittal view, which misses the pedicles or the sides of the posterior arch, and we'll talk about those in a minute, but you can see this giant canal, and this is called the central canal, or the central spinal canal, as I like to call it. Some call it the vertebral canal. But it houses a very important structure. In the neck and upper back, it houses the spinal cord. Since there's no spinal cord in the low back, it houses the thecal sac or dural sac. This bright white stuff, by the way, is cerebral spinal fluid, and that's how we can tell this is a T2 weighted image. Now let's look at the parts of a vertebra real quick. The vertebra has two parts. It has a vertebral body, which is a bean-shaped block of bone, and a posterior part called the posterior arch, which is, as the name describes, an arch of bone. Notice that the pedicles, which are the strongest part of the vertebra, connect the posterior arch to the vertebral body. It's pink here. I've tried to make these pink. Next, we have the articular pillars, which are important because they contain a superior and inferior articular process, which make up the facet joints. We've probably heard about the facet joints. Now, going posteriorly, now we have the thinnest, most delicate part of the lumbar vertebra, and that's the pars interarticularis. Now, if you have a spondylolysis or a spondylolisthesis, you're familiar with this term because the odds are this is where your fracture is or this is where your malformation is. I won't get into spondylolisthesis, but I have an entire page of that at chirogeek.com. Moving posteriorly, now we have the lamina, which is a curved piece of bone, and that's it. Then the structures repeat on the other side, and of course they form an arch where the thecal sac would be. Now, extending outward from the arch, we have these little airplane wings, and these are called the transverse processes, which are an attachment site for muscles and ligaments. And then we have, going straight back, we have the spinous process. Same, this is the same. It attaches muscles and ligaments here. If you put your arm and hand and palpate the back of your neck and you feel those bones, those are your spinous processes, and those of course run all the way down into your low back. Okay, now this is a CT view, computed axial tomography view, which shows the L4 vertebra. Now this cut is not through the disc level, but it's through the pedicle level, and we can see the arch quite nicely. Here's the pedicles, and the intervertebral foramen would be above and below this. The articular pillars would be here. The lamina would be here. Here's the spinous process, and the structures repeat on the other side. This hole, of course, is the central canal, and it houses the thecal sac. Now, here's another P to A view of someone standing. Notice that the inferior and superior articular processes make up the facet joint. There's a left and a right facet joint. These are true diarthroidal joints, just like the SI joint. Therefore, they have in reality a capsule around them and are filled with synovial fluid. They also, unfortunately, have nociceptive fiber, so they can become a source of chronic pain. In fact, in approximately 30% of you, this will be at least part of your pain generator. So it's a much more common pain generator than the SI joints. If we cut you like a lumberjack, if we saw you right in half here, right through the facet joints and right through the disc, you see the disc, that blue structure back there? Then we get a very important view. This is called the axial view. And this is a disc level cut, so we can see the intervertebral disc. Let's talk about the disc. The disc has two parts. It has a nucleus pulposus here in light green, and that is made up of 80% water. Why? Because the cells of the nucleus put out a molecule called a proteoglycan. And proteoglycans conglomerate together to form aggregans, and aggregans are like little sponges. They love water. They're very hydrophilic, and they grab water and hold on to it, and therefore we have a very watery structure here. Now this sloshy mess, because of the pressure on it, has to be held tightly in place, and that is accomplished by these rings of type 2 collagen, and they're called lamellae, these little dark structures here. There's usually about 12 of them per disc. And collectively, they make up a structure called the annulus fibrosus, which again, its job is to corral that nucleus tightly in place. When it does so, we have a beautiful example of a closed hydraulic system. Now, Here's the axial load coming down. What's axial load? That's the weight of your body, the weight of your head, and the weight of gravity pushing down on the discs. And now water, since it's incompressible, can't go anywhere as long as it's corralled by the annulus, so it becomes very hard and almost ball-bearing-like, and it sets up a perfect pivot point in the center of your vertebrae and in the center of your disc. So this is where all the range of motion occurs in your low back, or the majority of it. The flexion, extension, lateral rotation, lateral bending all occur right here. About 20% of the axial load is carried on the facet joints, which are like door stoppers. They prevent rotation movements, but 80% of the load is carried on this disc. That's a famous number for the disc because it's 80% water and it carries 80% of the axial load. Now, let's talk a little bit about the wiring and nerves of the disc, because this is important because it's where the pain comes from. Notice that the disc is literally infested in the outer 1/3 by these little nociceptive triggers. And these nociceptive receptors are like little pain on-off switches, like your light switch. If you flip the switch on, it's going to shoot an electrical signal of pain down the wiring up to the brain, and your brain's going to say, oh my goodness, I have pain. So these nociceptive fibers in the back of the disc, which, by the way, is where the highest density of these fibers is, they will transmit their signal of pain into the sinovertebral nerve, which I've marked in red here. And then it'll get up into the brain. Now, the pathway is very interesting. We used to think that the pain signals would loop around and go back in to the spinal cord. Therefore, we used to call this the recurrent meningeal nerve, and some books still do. But it's not a good name for this anymore, because the latest research demonstrates that these signals are actually carried not here, but they carry in through the sympathetic system, through the gray ramus communicans. They get into the sympathetic trunk, and they all, for whatever strange reason, they all seem to enter the L2 level. And they get into the L2 cord, and then they go up to the brain. So even the L5 disc seems to enter, the signals from the L5 disc seem to enter the L2 cord, which is very strange. But I talk a lot about that on my page. I won't take up any more time. But why did I take up time to mention that? Because this is one reason, again, why it's so difficult to make a diagnosis of disc herniation, because these things are all wired together. We also know that the sinovertebral nerves communicate above and below. So if this was the L4 disc, these sinovertebral nerves, not shown in this picture, but they would dive down and communicate with the L5 disc and go upward and communicate with the L3 disc. So things can get very confusing here. Now, if these nerves are irritated, typically you're going to experience severe low back pain. Now, not everybody. Some people are immune to this, and we don't completely understand why. But it has to do with annular tears. I'll talk about that a little bit in a minute. But typically, if these nerves get irritated, you're going to have low back pain. You might have a referred pain down your lower extremity, and sometimes it can mimic a dermatome, the discogenic referred pain, and that's similar to a heart attack. When someone gets a heart attack, they get that classic pain in the left arm. When there's nothing wrong with their left arm, but the brain gets confused as to where the pain is coming from. And it's got something to do with a phenomenon called divergence and convergence, but I won't get into all that here. But it can refer pain into your leg. And sometimes the disc can leak, and you can get a real chemical radicular pain, which I won't get into here, and I won't discuss that here either. But the take-home message is usually when these nerve fibers get irritated, back pain occurs. So what causes the sciatica typically? If either one of these two nerves get irritated, then you have sciatica. So let's talk about these. Now, this is the exiting lumbar nerve root. And notice that it is not inside the thecal sac. Why? Because it's already come out of the thecal sac. These nerve roots line up like airplanes on a tarmac waiting to take off. And typically behind the vertebral body, they poke and bud off the thecal sac, and they take some of the dura with them, so they are protected somewhat. And then they go downward, and then we can see them here on this disc level view. We won't see it as nice as this. We'll just see a piece of this because they're running obliquely out of the plane of the page here. Now, the traversing nerve root is right here, and that is getting ready to take off, but it's still protected and it's still within the thecal sac, so it has the advantage of having cerebrospinal fluid bathing it and surrounding it in greater quantities. When it buds off, it takes a little cerebrospinal fluid with it, but not nearly as much as it is here. So it's believed, at least I believe, that when these things bud off, they are much more vulnerable to compression and chemical leakage from the disc. So if this is the L4 disc, this would be the L5 traversing nerve root, which will come out below. And this is the exiting L4 nerve root. It's important to understand that. But notice that there are two nerve roots on each side that are vulnerable to a disc herniation. Okay, now this is one more. Let me back up quickly. One other point I want to make. Typically, the traversing nerve root is inside the thecal sac on an axial disc level cut. And therefore, on a T1 weighted, we won't be able to see it. L1, L2, L3, and sometimes L4, about 50-50 on L4. It'll be nice and protected here. See, this is an L4 T1 weighted disc level view, an axial view. And you can see here's the exiting L4 nerve root. There's the other one hugging right here. But you can't see the traversing roots because they're still within the thecal sac. Keep that in mind. Now, let's take a look at the L5 disc. Okay, same setup except for one thing. Now we have this Mickey Mouse appearance, and we have the traversing nerve roots are now outside of the thecal sac. So it looks like Mickey Mouse. There's his head, and those are his two ears. So this is why the L5 disc, I believe, is so vulnerable to injury, because these nerve roots are more exposed. They're just more sensitive. I mean, it still has dura around it, but it doesn't have all that cerebrospinal fluid, and it has no wiggle room at all. If you look at a L5 T1 weighted image, now you can see Mickey Mouse. There's his head. Those are the traversing nerve roots. Now, if this is L5, what nerve root is this? Good. That's the exiting L5 nerve root. There's the other one. And what nerve root is this? It's the traversing, but it's not the L6. We don't have an L6. It would have been nice because it's so common, but the nomenclature changes here. So this is the traversing S1 nerve root. Traversing S1 nerve root. Okay, now this is another cartoon, and what I've done, it's a posterior anterior view, and I have cut away the posterior arch by cutting through the pedicles right here. So I've peeled off the posterior arch, and now we can see the thecal sac. And I've even taken some of the thecal sac out so we can see the nerve roots inside. And you can see just that, how the nerve roots hang in this sac of fluid, and they're called the cauda equina collectively. But again, notice the budding here. The S1 nerve roots have already bud off the back of the L5 vertebrae. So when you see a disc level cut right through here, you'll see these out all by themselves. Now L4 varies. Sometimes it's right at the disc level, sometimes it's up higher, sometimes it's lower. But again, I think they're more vulnerable. We know for sure, I mean empirically again, from the surgeons I've talked to, that herniations that occur right at this bud-off point can be particularly painful. Now here's a sagittal view from the side again, just a cartoon, just to show you, and this always kind of really raises an eyebrow. I remember this was a, oh my goodness, moment when I realized that the L5 segment of the spinal cord is not down here at L5 where you think it would be. It's actually way up here at T12. And that's for some reason the spinal cord gets left behind when you grow. And therefore these nerve roots still have to come out of the IVFs So they have to kind of travel in this sac of fluid. The early anatomists thought that this looked like a horse's tail, which it actually does on a cadaver. It really does look like a horse's tail. So they called it the cauda equina, which is Latin for horse's tail. Now let's talk a little bit about disc nutrition. The living cells of the disc, the nucleus and annulus, they need food to live. And they need to get rid of their waste products just like any living tissue does. But the system is very strange because they don't have blood vessels. You can see the disc is almost completely avascular except for the very outer portion, which has a little blood supply. So the main feeding source is in the vertebral end plates right here. And this is where, of course, this is a cartoon, we would have capillary beds where fluid exchange occurs. And nutrients such as glucose and nitrogen and oxygen will diffuse through these little bitty pores, these little white holes in the hard bony end plate. These are very, very important for the disc health and survival. Here's a cartoon of the diffusion of these molecules. And any high school kid, or probably junior high nowadays, knows that diffusion through a semi-permeable membrane is a fairly slow process, especially when it's through a membrane which is a giant membrane such as the disc. I mean, this is a glycoprotein mass. Things move very slowly through here. So therefore, it's already a bad setup and the cells don't do very well to begin with. But now, if you get sclerosis of the end plate, which is an incredibly common thing, you can clog up these holes and the disc cells literally start to die. And when they die, they don't make proteoglycans and they don't hang on to water, and this disc material gets very brittle. Same with the type 2 collagen isn't being produced out here, and this gets very brittle. So you get something called degenerative disc disease. Again, I won't go into that, but I have a whole page on that. But the bottom line is, your disc, like this cartoon, can now rip and tear. And this is called a full thickness annular tear. And now we have allowed the degenerated nucleus pulposus, which contains these evil chemicals called cytokines, especially one called tumor necrosis factor alpha, interleukin 1, interleukin 6. They're pretty evil and they're like fire starters. They can soak into these nociceptors and start an inflammation, and the nociceptors will start firing pain messages to the brain, and there you have discogenic low back pain. Here's another cartoon. You can see a full thickness annular tear, and the nociceptors are angry, inflamed, and sending messages up to the brain. Another thing that happens when the disc rips, and I talked about this more in my YouTube video on disc herniations, but the beautiful biomechanics system is ruined. Biomechanics is completely screwed up, and the biomechanical studies have indicated that we get a weight-bearing shift posteriorly right over these already inflamed nociceptors. So now the pivot point isn't in the center when you're bending and twisting and moving around. Now the pivot point is right over these inflamed nociceptors. So that's the 1-2 punch. And the other component, the 1-2-3 punch, is now you have a pressure buildup here, which irritates the fibers anymore. So you get a biochemical irritation, a biomechanical irritation, and a pressure irritation. So 3 things that create a vicious cycle and cause low back pain from annular tears. Would this be visible on an MRI? Probably not. You don't always see these annular tears. So just because that MRI is innocent looking doesn't mean you don't have a full thickness annular tear, especially if the disc is black with degenerative disc disease. And in fact, here's a 25-year-old patient. This is a sagittal T2 weighted image where we have a beautiful L3 disc. It's white, just like the cerebrospinal fluid here, but the L4 and L5 discs are black with degeneration. And in fact, these have actually developed full thickness tears, and then some. The nuclear material is actually sticking out here in something called a herniation. Okay, we've come to the end of this video. Thanks for watching. Again, my name is Dr. Douglas Gillard, and I'm the owner and founder of ChiroGeek.com. I'm also a licensed chiropractic physician in the state of California. I've been licensed since 1987. I've treated thousands of patients, so I do know a thing or two about chronic low back pain. I'm also a professional spine researcher now, and in fact, I am published in some very high quality spine journals, including the #1 journal in the world, the journal Spine. So I'm not bragging here, but I'm just telling you that I do know a thing or two about the lumbar spine and the cervical and thoracic spine for that matter. Now, if you're one of my coaching service clients, I strongly recommend that you go on to the next video and learn about how to read your MRI. Although we're going to spend an hour together talking about your problem, that hour will go by very rapidly. So it really would behoove you to go through that MRI tutorial. That way the coaching service will go smoothly and you'll have plenty of time to ask your questions. Okay, thanks again for watching. We'll see you in the next video.